Good evening, everybody. Thank you, Dr. Khanna, for inviting me. Let me go straight to the case. This is a 71-year-old male, type A dissection in 2014 in an outside hospital, treated with an ascending aortic replacement. Came to our hospital in 2015 with an enlarged aneurysmal false lumen. Total debranching was done, followed by a TVAR with two grafts. Procedure was done by a previous IR in the same institution, not by me. Followed by followed up with the previous IR, and this was the notes of the previous IR saying that aortic aneurysm treated by debranching and TVAR. And most important is, if you see here, CT angio type 1 endoleak, no expansion in the aortic aneurysmal size, and a follow-up SOS continue with the medical treatment. So this was what the CT angio looked like when he had come to the previous IR. You can see that they have done debranching here, and they have done supposedly a pretty good job by sealing the aneurysm. He was lost to follow-up till 2019 June, that is last year, presented with a left shoulder pain. He was examined by a local GP in his hometown. He was asked for an X-ray chest, and the X-ray test showed this. Now, looking at this, the GP was worried and got a CT angio done. And this is what the CT angio shows. You can obviously see that there is a disruption of the graft, and you are seeing the aneurysm filling here, and there is a loss of integrity of the graft, the two grafts. So a CT was done at that point of time, and this is what the CT showed. There was a type 1 endoleak, as you can see there. And now what you see is that you are seeing an aneurysmal dilatation of the thoracoabdominal aorta. And of course, there is a loss of integrity of the graft. So what was the mistakes then? The first graft not positioned correctly, because you can see here, it is much higher than where the debranching was. Second was, the first graft was 40-40-200, and the second graft, which he had placed below, was a graft 38-38-200. So obviously, he has put a smaller graft into the larger graft. So we decided we'll take him up, took him for a TVAR and try and cover the entire graft. But when we tried to do that, if you can see, when we are trying to push the graft up, it would not track because of the aneurysmal dilatation of the thoracic abdominal aorta, thoracoabdominal aorta. So the only option was that the only way we can proceed is that we decided that we will get the wire, trap it in the right ventricle, and then pull it out from the femoral root, venous root, and then we have access on both sides, so it's like a flossing. And if you see, we did a transeptal puncture, and we snared the wire and got it down from the femoral vein. Once we got that, then we managed to get the whole device up. We extended the graft lower down and then covered the entire thoracoabdominal aorta. These are the videos showing you that we've covered the entire thoracoabdominal aorta. And then, just to be on the safe side, we had put a covered stent in the superior mesenteric so that we don't cover it. Thereafter, we did the balloon dilatation, and we seemed to have a pretty good result. And this is the angio post-procedure. Seem to have sealed it. There doesn't seem to be any primary or a secondary endoleak. And this is the still images to show you that there was no endoleak. So 1 month follow-up, this patient came back and we asked for a CT. And this is what we found. There is definitely an endoleak here. And not only that, there was another endoleak. So this was the upper one was a type 1A endoleak and type 1B endoleak here. So we said we can't leave him like this. So we decided to extend the graft lower down and put another reverse chimney, a little extension into the SMA. So once we did that, and we did the ballooning, we extended it lower down. And after we extended the thoracoabdominal segment graft lower down, we took a balloon dilated the whole segment, and we took an angio. And once you see the angio here, you are still seeing an endoleak lower down. Now we were in a fix. This guy has had multiple procedures. So we decided we'll go and seal it. So we used a balloon and said, "We'll let us balloon it again and see if we can help." Doesn't seem to be helping. So finally, we went into the endoleak. And if you see, you can see this micro catheter here, which is actually we are injecting Minox, which is a glue. And simultaneously, we are inflating the balloon so that there is no leak going down into the distal abdominal aorta. Once we do that, we seem to be having a completely good seal in the for the type 1B endoleak. And we decided now let us go to the top. So we were in a fix. How do we handle this? So we said that it's so close to the thoracic wall. So we decided we'll take a mini thoracotomy and then access it and go through the thrombus and reach the leak and try and glue it there. So that's what we did. We tried, but unfortunately what was happening was after we put in the sheath into the aneurysm, the glue was not reaching where we wanted it to reach. So the microcatheter we tracked only up to the superiorly, but we could not go inferiorly. So the contrast, if you see here, was tracking above but not below. Anyway, we injected some contrast there, some glue there, and immediately after that, we took him up for a CT. And this is what the CT shows. You're seeing here there is still an endoleak on top. However, there is no endoleak below. The type 1B endoleak that we are talking about. But there's a big leak, you can see type 1A. So this has been sealed. the lower end. So what we did was this was the only option. Sorry. So this is the only window we had. So we decided that the only way we can reach here is that we take a percutaneous access, and you can see this is the percutaneous access. We've taken a Chiba needle, a micropuncture needle, got under CT guidance, we've got a needle there, shifted the patient to the cath lab, changed over to a sheath, and thereafter we injected the whole segment with glue. This is the glue that we've been injecting, and we were very, very careful that it does not go antegradally into the ascending aorta. And final glue, after we've done the glue injection, you can see that the patient has got the glue. You don't see any contrast extravasation or endo leak, either for type 1A or type 1B. Right to the bottom, you're seeing here now that there is no type 1B endo leak. This was immediately after the procedure. This is a 4-month follow-up of the same patient. And again, you can see that there is no endo leak here. And no endo leak below. So, to conclude, the bottom line is the first attempt is the best attempt. Don't compromise at the first time. Plan the procedure. Planning of the procedure is vital, and leave no stone unturned to seal a type 1 endo leak. Thank you.
Thank you, Gireesh.
Gireesh, I just think fantastic. Congratulations. And what I admired most about this case isn't so much the different stages of it. It's your calmness about the way you've approached this and taking on a very, very difficult problem. I think this area is really at the very limit of endovascular surgery. It's like the last bastion area, and in the last presentation, we've heard about the Endologics device, but Miles Douglas, who invented it, he's trying to develop a branched graft for this territory because it would be such a better device to be able to put a branched graft in.
That is in the initial stage.
That would have been in the initial stage, absolutely.
Correct.
And
Correct.
the way you've persevered here has been wonderful to watch. And the calmness of your approach.
No, it's not. There's no calmness. I can assure you.
It reminds me of Patrice Bergeron. I used to go down in 1995, 96 to the south of France to watch him operate in the thoracic aorta, and I just loved the way he thought on his feet as he was doing it. So it reminds me of that. Fabulous. I mean, you're an Iron Man already. You're a star.
No. Thank you. But frankly speaking, we were so frustrated during the whole. This went on for nearly 3 to 4 months. The relatives were frustrated. I was frustrated, but I said, if I don't do anything for this, I mean, this man is going to die. Unfortunately, yeah. We should have done his 1-year CT follow-up right now, but because of this COVID crisis, he cannot travel to Mumbai. But if as soon as he can, he will come and we will do the 1-year follow-up.
Good, but maybe this is an exception where it is a good idea not to try and do everything at once, to follow up, to keep adding, to make it perfect with care and time, rather than expect to do it all the first time, or not that you were the first time, but when you're taking on such a difficult case, is to persevere with thought and care and time. Fantastic, fantastic result. Well done, you.
Thank you.
Okay, so that's perfect, Gireesh. So now we have two more things. One, that we'll open it for audience polling. While the judges are going to be discussing among themselves, they can do it on the chat box and decide who is the winner of Ironman in 2020. While the audience polling would be on for 30 seconds, and then we'll have the results.